For inviting me. It's a great pleasure to be here again. So this is just a brief overview. I'm not going to talk about every electrophysiological technique. I'm going to concentrate on two methods. But just to highlight, these methods are not idiosyncratic to Moorfields Eye Hospital. They're performed according to published international standards published by ISCEV, the International Society for Clinical Electrophysiology of Vision. And of course, the idea is that if everyone's using similar methods, it makes interlaboratory comparison meaningful. It's also actually very difficult to publish clinical electrophysiology unless you perform the tests according to these standards or incorporate them at least. So the first thing I want to talk about is the international standard full field ERG. And by definition, a full field ERG requires a full field or a Ganzfeld stimulus, something that will deliver a diffuse white flash that will illuminate the whole of the retina. The pupils are dilated, and that's to maximize illumination, but also, more importantly perhaps, to minimize intersubject variability and intersession variability. ERGs are often used to monitor efficacy of treatment, for example. It's important to try and maintain identical stimulus conditions between visits. Now, you can record ERGs using skin electrodes or corneal electrodes, and Marco showed an example of an HK electrode. This is the gold foil electrode that we favor at Moorfields, but there are other types available commercially. And for example, the contact lens electrode seems quite popular in the United States. So I just want to spend 2 minutes explaining the international standard minimum ERG protocol, because it's fundamental to everything really. So first, patients are dark adapted for a standard period of 20 minutes. And the 100 million rods become more sensitive than the 7 or 8 million cones, and a very dim white flash, which is below cone system threshold, is used to elicit the rod-specific ERG, or the dark adapted response to a flash strength of 0.01 candela seconds per meter squared. So this flash, it's dim, it's below cone system threshold, so this response is selective for the rod system. But there's a problem. If it's reduced, you can't tell whether there's photoreceptor dysfunction or bipolar cell dysfunction because it's actually generated in the rod on bipolar cells. And so we use a much stronger flash, 10 candela seconds per meter squared. And this strong flash ERG has both an A wave and a B wave. Now this is a strong flash. It's not selective for the rod system. It's a mixed rod and cone system ERG. But there's 100 million rods and 7 million dark adapted cones, so it's dominated by the rod system in healthy subjects. And for practical purposes, for most practical purposes, you can think of the A wave as reflecting rod photoreceptor activity, and the B wave, like the dim flash rod ERG, comes largely from the rod bipolar cells. But remember, there is a cone system contribution to both of those components. You can probably just detect these little wavelets on the ascending limb of the B wave. They're called oscillatory potentials, and they're generated by the amacrine cells in the inner retina. Patients are then light adapted in the Ganzfeld for a standard period of 10 minutes. That desensitizes the rods, and then a 30 Hertz flickering stimulus is used to elicit this flicker ERG. And the rationale is the rod system's slow. It doesn't respond beyond around 15 Hertz. So at 30 Hertz, you're effectively isolating the cone system. But there's a disadvantage because it's almost sinusoidal. It's a steady state evoked potential. And so we use a much slower flash at 1 Hertz to elicit the single flash cone ERG that has both an A wave and a B wave reflecting different cone system components or contributions. In actual fact, the B wave is sort of a composite of cone on and off bipolar activity. The A wave, perhaps surprisingly, comes largely from the cone off bipolars, but with a small cone photoreceptor contribution. So that's the international standard full field ERG. So I think I've already said this. So just to summarize. Now, it's not part of the international standard ERG, but recently ISCEV published some other techniques which could be added to the minimum protocol for specific clinical disorders, for specific applications. And one such response is the dark adapted red flash ERG. And the advantage in recording this is in the same waveform, there's a cone-mediated X wave and a rod-mediated B wave. So you can very easily look at the relative involvement of the rod and cone systems. And just think about the disorders where you'd want to assess cone system function, things like cone dystrophy or achromatopsia. Patients who are really very photophobic, and honestly, they struggle to tolerate a 30 hertz flickering light. So this gives an alternative method, a better tolerated method of assessing generalized cone system function. The on-off ERG involves LED stimulation, a light-emitting diode that's switched on for an extended period of 200 milliseconds and then switched off. And at onset, you get a B wave, and at offset, a D wave. And others have done pharmacological dissections on animal models and shown that the B wave is largely shaped by the depolarizing on-bipolar cells and the D wave by the hyperpolarizing off-bipolar cells. So this type of ERG allows you to look at different post-receptoral cone system mechanisms. It's a really important principle. The macula contributes virtually nothing to the full field ERG. So cone density may be greatest at the fovea, but the fovea is a tiny area compared with the retinal periphery. So you know there's about 200,000 cones in the fovea. There's 7 million cones in the periphery. And it's those 7 million cones that generate the photopic full field ERG. So just as an example, a patient with large areas of macular atrophy, the full field ERGs are normal. You know, by definition, patients with true macular dystrophy have normal full field ERGs. If the ERGs are abnormal, then it's a retinopathy or a retinal dystrophy. Clearly, we need some other method of assessing macular function, and a commonly used method, as mentioned by Marco, is the Pattern ERG, a response to an alternating checkerboard that impinges, that is focused just on the macula. N95 comes purely from the macular ganglion cells, as does about 70% of P50. But you know, for practical diagnostic purposes, P50 amplitude can be thought of as reflecting the activity of the macular cones. It's very closely related. It's driven by the macular cones. So if we just go back to the last case, there's macular atrophy, so no surprise that P50 is undetectable. And of course, you get N95 reduction just because it's generated downstream. In primary ganglion cell disease, for example, Leber's hereditary optic neuropathy, you might expect to see P50 preservation and selective attenuation of N95. But P50 is used to assess macular function. Okay, so some clinical examples of where there's predominant rod photoreceptor disease. And Marco's just given a great talk on retinitis pigmentosa. I'll not go into details, but I'll show one or two typical examples. This is a patient with typical signs of RP, good vision, and the dim flash rod ERG is undetectable. These are just normal examples for easy comparison along the bottom. So what does this tell us? There's severe loss in rod system function. The strong flash ERG A wave is reduced. So that allows us to localize the site of dysfunction to the level of the rod photoreceptors. There's A-wave reduction. And the light-adapted ERGs, well, not quite as abnormal as the dark-adapted responses. So in other words, this is consistent with a rod cone dystrophy. And in this particular patient, Pattern ERG P50 is reduced. So already the disease must have encroached upon the paracentral macula. The Pattern ERG is reduced. Now compare this subject, subject 1, with the next patient, S2. An even more severe rod cone dystrophy, but what about the Pattern ERG? What do you think? It's completely preserved. And the point is, in retinitis pigmentosa, you cannot predict the severity of macular involvement from the severity of the full field ERG. Now, you probably noticed that I selected these cases because they've got good acuity and they both manifest this common abnormality evident on fundus autofluorescence imaging in RP, this ring of increased signal. So what do you think happens if you compare our index of macular function, P50 amplitude, with the radius or the diameter of these rings? Well, we did that in 100 subjects, all with RP, all with good acuity. This is the ring radius, the autofluorescence ring radius, the size of the ring. This is our Pattern ERG P50 measure of macular function. All these cases have good vision, 6/9 or better. They were selected on that basis, but some have Pattern ERG evidence of macular dysfunction, which can be severe. Others have a normal Pattern ERG. And you can see this is the first subject we looked at and the second subject. So really suggesting that only areas within the ring were actually contributing to Pattern ERG P50. So the autofluorescence may be preserved over these paracentral regions, but these areas are severely dysfunctional. And we now know that these rings show progressive constriction with time. They mirror progressive photopic visual field constriction, and there's almost one-to-one correspondence with what's left, with the lateral extent of outer retinal preservation. So no surprise in retrospect that the areas outside the ring are severely dysfunctional. So I'm showing you this really just to demonstrate how well the Pattern ERG can assess macular function. Okay, a completely different case. See if you can get the diagnosis. A 9-year-old child with a short history of night vision problems, good acuity, normal fundi, and he's got some awful allergic syndrome. The dim flash rod ERG is undetectable, like in the patients with RP that we've just looked at. The strong flash ERG A wave is severely reduced, so we can localize dysfunction to the rod photoreceptors. And the light-adapted ERGs are completely normal. And the red flash ERG, well, it has the cone-mediated X wave, but the B wave is undetectable. So can you see the similarity between the red flash ERG X wave and the standard dark-adapted flash ERG? The B waves are of similar peak time. And what that actually suggests is that these abnormal dark-adapted bright flash ERGs are actually coming from the dark-adapted cone system. It is, in fact, the cone system contribution to the dark-adapted ERG exposed in the absence of any rod function. This is severe selective rod photoreceptor disease. So what do you think? What would you include in the differential? Absolutely. So the patient's got multiple food allergies. His serum vitamin A levels were less than 10% of normal. And of course, really important to spot this distinctive pattern of abnormality because it's treatable. Following supplementation, there's dramatic recovery in all of the rod-mediated responses, including the B wave and the red flash ERG. Now contrast that case with the next example. A 24-year-old woman with lifelong poor vision, poor colour vision, photophobia, and nystagmus, the dim flash rod ERG is normal. The red flash ERG, in this case, the B wave is preserved, but the cone-mediated X wave is absent. The strong flash ERG A wave is a little bit reduced, by about 20%, but the light-adapted ERGs are undetectable. So, anyone want to suggest a diagnosis based on the electrophysiology? So this is predominant cone system disease. It's severe selective cone system dysfunction. The strong flash ERG is slightly reduced because we've likely lost the small cone system contribution. And the dim flash rod ERG, selected for the rod system, is preserved. This is severe selective cone system dysfunction. Now, usually in progressive cone and cone rod dystrophies, the ERGs are abnormal. The cone ERGs are abnormal, delayed, reduced, but they are detectable. And to have undetectable ERGs, undetectable cone ERGs in such a young patient really shouts, really points to one diagnosis, which is achromatopsia or rod monochromacy. Many of these patients manifest these subfoveal cavities. And, really important to identify these cases because, as others have mentioned, there are now, therapeutic interventions, experimental treatments for CNGB3 and CNGA3 related disease. Okay, Stargardt disease. I won't go into details, just to mention the electrophysiology. In Stargardt disease, we see lots of patients with Stargardt disease, and we see those patients not for diagnostic reasons, but to establish the phenotype, the functional phenotype, which is difficult to predict, if not impossible to predict, from the appearance of the posterior pole or the fundus autofluorescence. So this patient has a large area of macular atrophy. The pattern ERG is undetectable, there's severe cone system dysfunction, but the ERGs are normal. This is a true macular dystrophy. In this patient, the fundus autofluorescence is perhaps less severe than in the previous case. There's macular dysfunction, but there's generalized cone system involvement. This is more like a cone dystrophy. And in a third case, macular dysfunction with severe cone system and rod system involvement, a severe cone rod or photoreceptor dystrophy. So we think in Stargardt disease, there's one of three functional phenotypes. And we think it's important because only 20% of those with an abnormal ERG in Stargardt disease go on to develop ERG abnormalities at 10 years follow-up. Whereas most of those, all of those with cone and cone rod dystrophy show ERG deterioration over the same period. So many patients at Moorfields are counseled according to the electrophysiology. In Stargardt disease, a normal ERG is considered of prognostic benefit to the patient in terms of retaining peripheral retinal function. Okay, I'm running out of time. So this is a 27-year-old with poor central vision, low myopia. I'm showing you this because, ERGs are rarely pathognomonic. They rarely specify a single gene, a single diagnosis. But this is one of about 4 or 5 examples where the ERGs are pathognomonic. And just to summarize, there's generalized cone system dysfunction, but there's unusual rod system involvement whereby responses to the dimmest flashes are attenuated and those to the stronger flashes almost augmented. And I don't know whether you can see, but the A-wave shape in the strong flash ERG has almost a square wave appearance. And you only see that in this disorder. And this is known as cone dystrophy with supernormal rod ERG, or KCNB2 retinopathy. And the point is, the fundus appearance can be highly variable, but the electrophysiology is pathognomonic and specifies the gene responsible. Now, I've actually ordered these in age order. This child is about 10. This patient is about 60. They all have genetically confirmed KCNB2 related disease. And it's just to show how, with time, these patients tend to develop maculopathy, a ring of hyperfluorescence surrounding a central area of atrophy. And certainly younger patients can also manifest this subfoveal cavity. But as we've seen, there's nothing specific about that subfoveal cavitation. You can see it in KCNB2, in achromatopsia. It's rather similar to what you see in occult macular dystrophy, solar retinopathy, maybe a little bit like pauperetinopathy, and in some young cases of Stargardt disease. Obviously, the history is important, symptoms important, but of course, patients don't always report typical symptoms, and the signs are sometimes equivocal. And electrophysiology can help distinguish between these disorders. Okay, a quick example of inner retinal dysfunction. So this is a 47-year-old man, poor vision since childhood, down to 660 bilaterally. There's macular atrophy. It's evident on autofluorescence imaging, and the atrophy is surrounded by a ring of hyperfluorescence. In brief, the strong flash ERG is electronegative. The A wave is preserved, but the B to A ratio is less than 1, indicating dysfunction that's occurring after phototransduction. So any suggestions? Thank you. It's too easy. So male patient, poor vision since childhood, macular changes, and significantly, ERG evidence of inner retinal dysfunction. So just highlighting how, in X-linked retinoschisis, you don't always see these classic sort of stellate lesions or macular schisis. Especially in middle-aged men, that can give way to non-specific atrophy. And the ERGs can help, pinpoint the diagnosis. These are all genetically confirmed cases, just showing, fundus autofluorescence phenotype variability. The ERGs can also be variable. So here, I've plotted the B to A ratio in the strong flash ERG for about 45 genetically confirmed cases. Look how many have an electronegative response or an abnormally low B to A ratio. So there is variability, but most patients with X-linked retinoschisis have evidence of inner retinal dysfunction on ERG testing. Nothing specific about the schisis. Again, you can see that in, in isolation. You can get foveal schisis, enhanced S-cone syndrome, and it's somewhat similar to the schitic-like lesions you see in autosomal recessive bestrophinopathy. And the ERGs can help distinguish these orders, especially if the history is not typical. I'm sure there's other causes, perhaps tractional and degenerative changes that can also manifest somewhat similar ERG changes. So finally, I just want to highlight this recent guide published by ISCEV, which describes the basic techniques, highlights typical cases, and in fact also includes a table of disorders where electrophysiology is probably most useful. Thank you.
Any questions? Okay. Tony, how often... Okay. How often do you think that we have to repeat electrophysiology in a patient with Stargardt disease, and how often in a patient with RP?
So I think in Stargardt disease, you want the functional phenotype. If the ERGs are normal, I wouldn't see a great need to repeat them in the near future. If, inevitably, occasionally, ERGs are borderline, and sometimes it can be difficult to establish a precise functional phenotype, and in such cases, you might want to repeat the ERGs in a couple of years, just to check the stability of the cone ERGs or to look at whether there's significant change. And in RP, once you've established the diagnosis, unless the patients are being monitored for some sort of experimental therapy, there's probably not a great need to perform the full field ERGs. Okay. At least, for maybe 5 years or more.
I think that's absolutely right. I guess for Stargardt, if they're having new symptoms, so if they're patients who now start to complain of night vision problems, then I might then repeat it to see if there's any functional correlate to their symptoms. That there isn't always, so that would be when I would redo it for Stargardt, but otherwise I'd agree. Tony, do you want a couple of sentences on the pros and cons of handheld ERG?
Yes, I mean handheld ERG as in a strobe. So, you know, children, obviously, limited compliance. They won't sit at a Ganzfeld for an hour, however long it takes. And we use a simplified pediatric protocol, often involving the use of skin electrodes and a handheld strobe, which we can direct at the often, you know, restless child. With skin electrodes and a strobe, you know, it's very difficult to detect subtle abnormalities, but then I think, you know, in infants and young children, you are hardly ever looking for subtle changes. It's much more a case of, you know, is there an ERG detectable? Is the rod system intact? Is there an electronegative ERG? Why has the patient got nystagmus? Is there a cone dystrophy, for example? Is it CSMB or a rod cone dystrophy? So I think, you know, the questions in infants and young children are much broader, and a handheld strobe and surface electrodes is often sufficient to confirm or exclude any of those conditions. And I think, you know, looking for subtle abnormalities in children is almost impossible because they're not fully compliant. They close their eyes, they shake their heads. And
I totally agree with you.
Yeah.
It's really helpful to have a simple, full-field ERG for children. It's really helpful. It gives us many times diagnosis.
Yes. And we tend, you know, to adapt the protocol according to the level of compliance. We concentrate on recording a flicker ERG to assess the cone system. We try and record a single flash rod ERG after 5 or 10 minutes dark adaptation. But our approach is systematic. And if children are mature enough and they're comfortable, often we'll just extend the protocol according to their ability to comply with testing.
How often do you repeat an ERG in a child?
Yeah, we have a fairly low threshold for repeating electrophysiology in children, especially if there's any possible sort of neurological
And
suspicion.
I think it depends on the compliance. I mean, if I feel comfortable with the ERG that the child was okay.
Yes, and I think often if they've been once, they are perhaps less anxious if they come back for the same procedure. You know, they're more used to the environment and less afraid.
Let's move to the next talk. Michael Miklidis.